Welcome to Discover Midwives, the podcast where we explore the art, science, and impact of midwifery. I'm Jessica Brumley, and each episode we'll uncover the stories, the history, and the expertise of midwives. This is your space to learn, connect, and celebrate the power of midwifery. Let's discover midwives together. Welcome to Discover Midwives. Today we have with us Julie Knutson. Julie is an assistant professor with the Brown OBGYN Residency Program in Providence, Rhode Island. She's worked in freestanding birth centers, public health clinics, and in several hospitals in the US. She collaborated on the genetics chapter in our sort of landmark classic midwifery textbook, Varney's Midwifery. And then tackled an article for the Journal of Midwifery and Women's Health on cell-free DNA testing. And even after all of that, we agree that this is still a really complicated topic. But she really hoped that this article provided an unbiased framework for midwives to use in navigating NIPT or non-invasive prenatal testing options with their clients. And when I read the article, I said, we have to have Julie on our podcast, because if we find this confusing, imagine how our patients are feeling. And so I just want to say, welcome, Julie.
Hi, thanks for having
me. Thank you so much for joining. I always like to start with a story, and I'm going to start with my own, kind of story. And then I'm going to ask you some questions, Julie. So I think about the history of genetic testing in pregnancy throughout my career and throughout my pregnancies, because I had my son in 2002. And at that time, we had available to us what we call quad screening. And this is a blood test that would check for 4 different hormone levels. And it had this really high, I think of now, sort of unacceptable false positive rate. And I knew that if that test was negative, that I should feel really good. But if it was positive, literally couple times a week, I would be counseling patients on this like high risk of false positive. And I almost didn't get it in my pregnancy. And I just said, okay, I'm going to get it. I'll feel better if it's negative. It is what it is. By the time I had my daughter, that was almost 5 years later in 2007, first trimester screening, right, with ultrasound was becoming available, just sort of starting to become available. So you would do an ultrasound at around 12 weeks and you would get this blood work, and it was better than the quad screening. But it was new, and I felt really uncomfortable with these like extra ultrasounds that were being recommended, and I didn't really feel super comfortable with that test, and so I just skipped it. And the second time around, and then a few years later, I started hearing about this cell-free DNA testing or non-invasive prenatal testing. I heard it at a conference, and when they talked about the data, I thought, oh, why don't we do this where I work? And sure enough, within a few months, we were. And at that time, it was only recommended for people who had risk factors, right, for the conditions that this test screens for. And since then, it's become recommended for everyone. And so I just sort of like shared my story to share some of the history of testing that we have been able to offer, over the last couple of decades. And I wondered, Julie, if you could tell us a little about yourself and what made you decide to publish an article on cell-free DNA testing.
So I decided to do this article based on when I was working in a birth center, a freestanding birth center, and we used a specific company, as I think most clinics and settings do. They have one specific company that they use for genetic testing. And I felt like most of my knowledge about the test was based on what the representative from the company came to the birth center presented on. So, and they were very kind of laid back about it. This is, it's a great test. It screens for, I don't know, maybe 25 different conditions. And if your insurance doesn't cover it, we'll figure out a personal payment plan so that basically it can be accessible to anyone because it's sliding scale, sort of based on how much you can pay. And it just sounded like, from the patient perspective, oh, this is great. I can get this test done and it'll, basically tell me that my baby's fine, doesn't have any of these problems. And then this went on for a while, and eventually I thought, you know what, I don't actually know what tests are recommended out of these. Like, did the national organizations like ACOG or like ACNM, do they recommend that people get all of these tests or screen for all of these tests? And I did some reading about it and learned quite a bit, which is why I published this article. Mostly initially for my own learning, but also obviously now so that other midwives have a kind of more of an unbiased perspective on what the purpose of the test is, what's available, and how to better counsel patients on whether or not they should get the test. And when I became a midwife too, we did have the cell-free DNA was not available. And I worked at several public health clinics where even after it did become available, it wasn't available to the patients that I was serving because of the cost. But as you said, now it is the recommended test for anyone regardless of risk, based on the fact that it's a lot more accurate than the serum screening or the quad screen. However, that doesn't mean that all insurance companies will cover the test. So it is still payment and coverage is still an issue that many people face. And again, it depends on where you live in the country and which insurance you have and what the specific company whose test you're using is willing to quote you as a rate, because it is very individualized.
I was surprised to hear that, or to read that in your article. We get, we get used to where we practice and what's available, and think that it's like that, everywhere for sure.
Yeah,
So,
and there are a lot of different test options from a lot of different companies. So
mhm.
if you work at a clinic though, and they only use, I don't know, Natera, for example, you might think that's the only test out there, but there are many different companies which are listed in my article. And
Yes.
that's not an exhaustive list either. I'm sure there are new companies since the article was published a couple of years ago.
So this test that we, keep sort of referring to, this cell-free DNA testing, it will get offered likely very early in the pregnancy. So for our consumers out there, what is this cell-free DNA testing?
Sure. You might hear of it called a few different names. So can also be called non-invasive prenatal screening or non-invasive prenatal testing. It's considered non-invasive because even though a blood draw might sound invasive, it's a blood draw of the person who's pregnant. And then it kind of remarkably looks for fetal or the baby's DNA that's floating in the pregnant person's bloodstream. And that percentage of fetal DNA in the pregnant person's bloodstream increases during pregnancy, and it averages about 10%. So that's kind of wild to think about, that if you're pregnant, about 10% of the DNA fragments floating in your body are from your baby. But that's how the test works. Is the DNA transfers through the placenta into the maternal bloodstream. So it's most effective after about 10 weeks of pregnancy, because before that, as you can imagine, the amount of fetal cells in DNA is so small that the test just isn't accurate, or the fetal fraction isn't enough to be able to evaluate the baby's DNA. And then this differs from invasive testing in that it's a screening test, and we can talk more about why that's the case. But the invasive option is an amniocentesis or a chorionic villus sampling test. And those tests actually do insert a needle into the pregnancy and gather DNA from the pregnancy, and then they actually analyze the baby's DNA, compared to the cell-free DNA or non-invasive screening is looking at basically broken down fragments of the baby's DNA that are floating around in the pregnant person's bloodstream. So it's an indirect way of evaluating the baby's DNA.
So it's less invasive, right? It's like the
Yes.
it's
I
not
think it's a
totally
misnomer to call
uninvasive.
it non-invasive.
Yeah. Yeah.
But it's
And
an easy test to collect. You can do it from anywhere that gathers, where you can get a blood draw. You can, so long as the lab offers the test, you can have the blood draw to get this test.
so we're picking up on the baby's DNA inside of the pregnant person as early as 10 weeks in the pregnancy. I also love that there's no end date. A lot of these other tests that we used to do, there was this narrow window of time when you could do that test. But if somebody presents to me for their first prenatal visit at 32 weeks in their pregnancy and they want this test, they can have this test, right? It's still
Yeah.
information that may be valuable to that individual.
Yeah.
I like that too. And what is it that we're testing for?
Well, as mentioned, you can hypothetically test for an unlimited number of conditions. So, and I think that as time goes on, we'll find that these companies are offering a lot more conditions that you can screen for. But currently the national organizations that have opinions about prenatal testing, such as ACOG and SMFM, recommend that the test be offered specifically for trisomies 21, 13, and 18, which is Down syndrome.
Patal, right?
Patel, and which one is 18? I'm blanking on whoever they were named after now. But trisomies essentially means that there's an extra set of chromosomes in the baby's DNA. And the kind of expected manifestation in the baby can vary quite a bit. Trisomy 21, which is Down syndrome, people with Down syndrome can be very functional. They may have some, functional disabilities and physical disabilities, such as cardiac defects. But they might live a long life, a full life. Whereas babies born with trisomy 13 aren't expected to live very long if they are born living. And trisomy 18, there can be a wide variety of how that manifests in the baby. But usually it's not compatible with life either.
Yeah, right. Um, a lot of people tell me, and I'm sure you hear it too, I want the test that tells me the sex of the baby.
Yeah.
How,
So,
can you talk a little about that?
yes. So cell-free DNA also can screen for sex chromosome aneuploidies. And so an example of that is monosomy X or Turner syndrome. There are several different variations, though, on sex linked disorders. So because it can test for sex chromosome aneuploidies, it can also tell you the baby's sex. And I think many patients want the test just because they're curious to know, or they want to know if they're going to have a boy or a girl. But it's not that straightforward all of the time, because, well, for many reasons. But one is that a baby can have, for example, an XY genetics, that their genetically female, but then they might be born with anatomy that does not look female. So it can lead to some ethical conundrums for the baby or the family. And likewise, the test could also find that the person who's pregnant has a sex-linked or a sex chromosome aneuploidy that they didn't know about. So, for example, they could have monosomy X and not know it, and then they find out about that as a consequence of getting the test. So, and then also patients could find out that the baby has a sex-linked aneuploidy, and if they don't get the appropriate genetic counseling or support services available, they might just be left with this information that they don't know what to do with or can't do anything with. So I think when counseling patients, it's important to explain what information they may get from the test results and to also link them with appropriate resources so they can be more informed in addition to just the test result. This came up with someone remotely related to me contacted me after their baby was born, and the baby had, I think, XXY, which they found out at a first trimester cell-free DNA test. And then I think kind of just went on with the pregnancy, didn't seek any information. I'm not sure if they had genetic counseling, but they reached out to me when the baby was after they were born in the NICU, saying they felt like none of the providers knew anything about this condition, and could I send them some information? And I just felt like, how did this even happen that this person had this test result and then somehow went through the whole pregnancy, it seemed like, without getting any support services or other information, and now they have this baby with health problems and they don't know anything about it. So I feel like that's a potentially serious gap and problem people might face after having these tests.
So often when we have these conversations with the people that we're caring for, and if someone's considering not having the test, right? Like, well, I wouldn't do anything if it was a problem, is oftentimes a reason why somebody tells me that they don't want to do the test. But doing something sometimes just means preparing for the baby that you're going to receive. I can't agree more. Like, that is, to me, that is the benefit of the test, is that you're not in shock when the baby is born. You are ready to welcome the baby that you have conceived and given birth to, right? Oh, so that breaks my heart that
Yeah.
that happened to that, that family. Yeah.
Well,
So
and obviously one reason that people do have this testing done is if they wouldn't continue pregnancy, for example, with a baby that's not viable. So if the test result is trisomy 13, and it's likely the baby's either going to die before it's born or shortly thereafter, then they might choose to terminate the pregnancy. Um, so that's one reason that people do get this screening test. But then, as you said, another personal example is I was working in the freestanding birth center setting and with a client who'd had a previous pregnancy with a trisomy diagnosis, and um, they they chose to give birth in the birth center setting, knowing that the baby was going to be born and compatible with life. So, but that was like important information for the caregivers to know, to prepare emotionally for that type of birth. And then likewise, people might choose not to give birth in an out of hospital setting if they knew that their baby was going to, for example, trisomy 21 might have cardiac defects, should have ultrasound follow-up and things to make sure to check on what sort of anomalies you might expect at the time of birth, what kind of extra support the baby might need. But if a family is choosing to continue the pregnancy with trisomy 21, they might choose to give birth in a hospital instead of out of hospital to have pediatricians close by or a NICU close by. So um, like you said, just being more prepared for the circumstances surrounding the birth, I think, is a good reason to have the test.
so these are major decisions that families are are needing to make, right? Continue the pregnancy, be prepared, not continue the pregnancy. And you want, I think, the most reliable information to be able to make these decisions. So can you talk a little bit about the distinction, between screening tests, diagnostic tests, like, how reliable is the information that somebody is getting to help make them these decisions?
Yes. So that goes into why this is still considered, even though it's 99% accurate for detecting trisomy 21, it's still a screening test in that. Um, so as we mentioned, the fetal DNA comes through the placenta, and it's possible, it's rare, but it's possible that the um, trisomy or the aneuploidy could be only concentrated to the placental tissue and not in the actual fetus. So that's called placental mosaicism. So it's possible that it's like the placenta has the mutation, but the baby itself doesn't have the mutation. And so if anyone has a positive screening cell-free DNA test, it's recommended that they then get a follow-up invasive test or an amniocentesis or a CBS. And so that the amniocentesis is the reason that we don't just do amniocentesis on everybody is that you actually have a needle inserted into the pregnancy. And obviously, there's some risks associated with that, including very rare, but can affect the fetus development and or could cause spontaneous miscarriage. And it is very rare, but it's why we don't just routinely do that test first, why we prefer to do a blood screening test first. And then as far as the predictive value of these screening tests, the cell-free DNA is most accurate with 4 mutations that are more common. So trisomy 21 is comparatively more common in the population, but its frequency increases with the age of the pregnant person. So someone who's pregnant and 45 is much more likely to have a baby with trisomy 21 than someone who's 21 years old and pregnant. And so the positive predictive value of the test is better for people at more advanced age because the condition is more prevalent in that at that age. So this is part of why it's not routinely recommended that we screen for, currently recommended that we screen for all these other possible conditions that might be detected with cell-free DNA because their prevalence is so much lower in the general population that the positive predictive value of the test becomes much less. So what that means is that it's more possible that a person could have a positive result, meaning that they screen positive that the baby could have a condition, and then it's actually a false positive, meaning that the baby doesn't actually have the condition. But that's why we recommend follow up with a diagnostic test such as an amniocentesis is to confirm the diagnosis before making any other decisions, including pregnancy termination, and or kind of just for the pregnant person's planning. If it's the baby actually doesn't have the condition, you wouldn't want that person to go through the whole pregnancy preparing that the baby be born with a condition that they don't actually have.
Yeah, and the angst, right? The reason why they don't recommend these expansive tests yet, I don't know, right? Like maybe these tests will improve in the future. Is that higher chance of it being that false positive, and what that means to that family, like that, do you even still bond and connect with that baby? What's the stress? What's the anxiety or the depression that can be associated with this potential diagnosis that might not even come to fruition? So when we're thinking about the cost quote unquote of a test, it's not only the financial cost but like the emotional ramifications of of a test. I definitely have, and I'm sure you have as well, had people say, I don't want to know. Like I know I would just be so stressed for the whole rest of my pregnancy. And then other people say, I have to know. I will be so stressed for the rest of my pregnancy.
Yeah.
Right? And so that's a really individual, personal, decision. So even though this is a test that is recommended, quote unquote, by these professional organizations, it's not something that I mean, everybody has to have anything, but it's not something that, we will say you have to have, or, it's really a personal choice.
Yeah.
Yeah.
And I think a common misconception amongst patients too, I kind of already said this, but is that if they have a test and it's a normal result, that means their baby doesn't have any problems whatsoever. But there are hundreds, if not thousands, of genetic conditions that aren't screened for by these tests. And, they range from manifesting as autism or skeletal abnormalities, or there's like a million different ways in which your genome can be um, affected or manifest that is not screened by these tests. So, as time goes on, it's possible as technology improves, I guess, that and this is already in the works, that these cell-free DNA tests might screen the entire genome, um, in which case you could detect any sort of mutation or, changes in a person's DNA. And then I think it'll be important for patients to decide if they want to know all of their baby's information, DNA information or not, especially when there may or may not be anything you can do about it. And it might
Oof.
impact the way you would think about your child um, when the individual themselves might not actually, manifest as different from other people in any perceivable way. But you know that they have this change in their DNA, so it might impact the way you think about that person.
Heavy stuff. We talked about this a little bit, but I wonder if we can't kind of break it down. Okay, so you come in, you get offered this test, and you decide to have it, and you get a negative result. So there's kind of three different pathways that could happen, right? You get a negative result, and you've just said the negative result is reassuring in general. There may be some random things that we don't pick up, but that's kind of like the end of that pathway. Then there's the possibility that you have an inconclusive result. And we really haven't touched on that. So I wonder maybe if you can't talk a little bit about these like indeterminate results that can happen. Yeah.
Sure. So the most common reason for indeterminate result is just that the test was collected too early, so there's not enough fetal DNA in the bloodstream. That can happen if a person's due date is a little bit off. So we think they're 10 weeks, but they're actually 8 weeks. But other situations can also lead to an indeterminate result, including another reason for this happening is a person's BMI. So, at a greater BMI, you're more likely to get an indeterminate result. Um, and if that happens, it's actually recommended that you follow up with an invasive test like an amniocentesis rather than repeating the cell-free DNA test. And the reason is because the indeterminate results are more associated with trisomies or aneuploidies. So it's not the same thing as a positive result, meaning that yes, the test is screening positive for a trisomy, but it's more possible than with a negative result.
So if someone has an indeterminate result, they would probably get referred to genetic counseling and or MFM. Is
Yes.
that fair to say? and it's kind of treated like a positive result in that regard.
Yeah, for the
Hmm.
follow-up.
Hmm.
Mhm.
Yeah. So then if somebody has a positive result, then it's usually positive for a specific thing, right? So the test will tell us what it's positive for. It's not like we just clump everything together and say, this is positive, you're positive for something. You'll get this specific result. So then you might get some information about that specific condition that it's positive for. And then again would get referred to some kind of genetic counseling and maternal fetal medicine consultation.
Yes.
And probably in that consultation, you'll be advised that you have the option and recommendation for invasive testing in the form of an amniocentesis.
Yes.
Yes. Okay. So if people are out there and they're having these positive results or indeterminate results, and they're not getting additional information and they're not getting referred to some kind of specialist to have this more in-depth conversation, they should ask for it or seek it out. Yeah, I think that's like a
I would
public
assume,
service announcement.
yeah, I would assume that in low resource settings that access to genetic counselors is and MFM services is less.
Hmm.
I
Hmm.
assume
Yeah,
that is happening.
for
I
sure.
live in New England right now, and we have such a high concentration of medical providers here that that's not. I don't think access is an issue, but I imagine it is in much of the U.S.
Yeah, I think that's a really fair point. I mean, also we have these huge maternity care deserts in the US, and for specialists that's even greater because there's, so few of those specialists. But I would say that telehealth has really changed the availability, right? So these are the kinds of things that start with a conversation, information sharing, and don't necessarily require you to come in for an in-person visit. So if you are really remote from that kind of specialist, then it could totally be a phone call conversation or a video, conversation. And some of the labs that we use have genetic counselors available for the clients to be able to contact them that way. So yeah, more information at the very least is warranted, for sure. Yeah. So we've alluded to so many of the things that these tests can test for, the whole genome. But what are other things people can potentially learn from their selfie DNA testing? Are there any specific examples that maybe you might highlight?
Um, a new kind of exciting one, I think, is
Mhm.
whether or not someone who's Rh negative blood type needs to get a RhoGAM shot based on their baby's blood type. So historically, if you had Rh negative blood type, you would be offered RhoGAM at um, around 20 weeks gestation and then right after you give birth. But RhoGAM is a blood product, so it's derived from donated blood. So it's not like it's an unlimited resource. But what it does is it helps the person who's pregnant from developing antibodies that would basically attack a future pregnancy if they were pregnant with a baby who had a positive blood type. So they have the negative blood type. RhoGAM shot helps prevent them from developing antibodies that would kind of attack a positive blood type baby. So cell-free DNA now has the capacity to screen the current baby for their blood type and then determine whether or not that means that the person who's pregnant needs to get a RhoGAM shot. So it theoretically can decrease the amount of donated blood product that is used to develop the RhoGAM injection. And for someone who doesn't need the RhoGAM injection because they're Rh negative, but their baby's also Rh negative, it just helps prevent them from needing to get a shot that they don't need.
And that's not yet available with all of the labs. Is that right?
Correct. There's just, as far as I know, a couple. that.
Yes. And so it's not like it's not yet the standard. I would say like, what we call the standard of care. But I agree.
Yeah.
I think it's an exciting new bit of information that I would bet we'll start to, see more of. Yeah. Yeah, that's cool.
Again,
Um,
because it's a
mhm.
screening test, there is like the very rare chance that people could be missed. So if you have an incorrect result and it turns out actually you should have gotten ROGAM, but the test said you didn't need it. I think it's something like 3 in a million. I don't know. Potential false negatives with using cell-free DNA for that purpose. So it's a pretty accurate test, but it's not diagnostic, so not 100%.
Yeah. Yeah. And for some people, that would be enough for them to feel like I'm just going to get the ROGAM. But for other people, it might be enough for them to say, I felt really uncomfortable, with getting any kind of medication in pregnancy. So I'm gonna, skip that till the baby's born or something. It's all about presenting the information and letting, people, make that decision for themselves. And that process of shared decision making, I think, is really where the midwife can shine in this, in this, in this area. I think our role is really important, not necessarily to interpret every super complex genetic result all by ourselves, right? Because, like you said, this is complex. We sometimes we feel like, whew, it's going over our head. But to help people make informed decisions. And so I wonder, if you might talk about what does good pre-test counseling look like?
Well, this is part of the problem, is that the amount of time we have with people is limited, right? And so you could easily spend an hour, I think, talking about these tests, and we don't have an hour with people usually during prenatal appointments. So using, I think, videos and other ways of information sharing can be helpful so that patients can come to their appointment understanding a little bit what the test is for, and think about whether or not they might want it is, I think, helpful. Um, could be helpful. Another thing to consider is that patients don't have to, like you said, you can get this test anytime in pregnancy. They don't have to make a decision on the first appointment where you're talking about with them. You can present the information, what the test is looking for, um, what the different options are for testing. For example, most labs will offer a test that just looks for the trisomies 21, 13, and 18, or you can, usually it's opt out for the sex chromosome aneuploidies. Um, and then, there usually is another option for a lot more extensive testing. So you can explain the test to patients on an initial encounter, and then have them go research it more, provide some resources so they can learn more about the different testing conditions, and then make a decision at a subsequent appointment. I think it's important to offer this to everybody, and then again, whether or not how much they might end up paying, that largely does depend on their own insurance and where they live. And then also explaining what the tests don't screen for is important, I think. As I think I've said a few times, I think it's easy for people to think they get a negative genetic screening test result, and they think that means that there's no possible genetic condition that their baby might have, and that's just not the case.
Yeah. Yeah.
It's usually looking for very specific conditions, and um, as we said, if the screen comes back positive for a given condition, it is not a diagnosis. They should have a follow-up um, diagnostic test.
We do
And
have handouts that we use for our patients, but I love this idea of a video. Do you have any like suggested resources where people can find videos on this topic? It's okay if the answer is
unfortunately,
no.
um, I know there have been studies that show that using videos is useful.
Mm,
I'm not,
So,
for the last 6 years, I'm not in a setting where I provide prenatal care. So I'm sure there are a lot more videos available that I just don't know about right
yeah, it's
now.
okay. Yeah. Um, yeah, well, I think I'm gonna go look for some. So another issue that you raise in this article is genetic privacy. And that one really, I found that really interesting. I hadn't thought about it. So what should patients know about what happens to their DNA after their blood is drawn for cell-free DNA testing?
Yeah, this is fascinating. So I think it varies a lot depending on the lab, but I don't think it's uncommon that they use the DNA for additional testing, or they put it into these biobanks that are supposedly de-identified genetic material, but that these companies can use for um, additional research. And so it's usually the lab should provide a disclosure form on what will happen to the genetic material after it's collected. And I think it's important for providers and patients to use labs that offer this disclosure. So I think, um, I don't want to sound like conspiracy theorist, but I think it's theoretically possible that a patient's genetic information could be out there still with identifying information, and that in the future their identity could be linked with the genetic um, condition, and then that could hypothetically have consequences for their life insurance or health insurance coverage. So I don't know particular examples of that, but I do know it's something to look into, that to at least make sure you're using a lab that does disclose what they do with the genetic information after they run your test.
It's like the world in which we live. We have so much information that out in the universe that would historically have been private information, right? Like, I mean, but now we're living in a much more public way, and I think this is one example of that. Certainly something for people to consider. Um, yeah, yeah. It's just fascinating. I had not considered that at all. Um,
I think the like 23andMe tests where you
mhm.
get I don't know this, but I sort of wonder if you find out that you have a genetic condition, if when you do apply in the future for life insurance or health insurance, if that it's possible that you're required to disclose these conditions that you've been diagnosed with, and then if that would then impact your ability to qualify for certain coverage.
Yeah, I had somebody close to me recently who said that part of the reason why they would not complete one of those tests is because of the privacy concerns around it, and that it just wasn't satisfactory for them. So, yeah, so I think a lot of people are thinking about that, and so this is something I think it's an important topic. Maybe a whole ethics like article or piece. Yeah. So what would you say to someone who is feeling overwhelmed by all the prenatal testing options and simply doesn't know where to start?
I would say don't do it yet. don't don't do any test until you feel comfortable with the potential consequences. And but obviously in pregnancy there's certain things that are time sensitive. So unfortunately, if someone would terminate a pregnancy based on a condition and lives in in a place where that's legal to do, there's usually still time limits on when they can do that. So therein lies the time pressure. But even despite that, I think if someone is just feeling overwhelmed and not comfortable, first ask your provider if you can talk about it more. Um, but don't do anything that you don't feel comfortable with.
Yeah. I wanted to mention this earlier. when we talked about restrictions in the US around termination of pregnancy, even in states, because I live in a restrictive state, even in states where there are significant restrictions, most of them have language around conditions that are incompatible with life, which right and that would permit a termination of pregnancy even later than the otherwise, right? Or so I think that that's important information for the public to know. Yeah, definitely.
And I mean, and also considering that a termination is usually easier on the pregnant person's body if it's done earlier rather
Hmm.
than during pregnancy.
Yeah, yeah,
So there are
yeah.
benefits to finding out the information sooner rather than later.
Thank you so much, Julie. I think this was a really important conversation. I hope people, find it helpful and it helps them to be able to make the decisions that they, will be presented with when they come in for prenatal care. And I just wanted to ask if there was anything else that you wanted to share with our listeners, anything that we didn't cover today.
Nothing coming to mind.
All right. Yeah, fair. I think we had a great robust conversation. Yeah, absolutely. Thank you. Thank you all for listening. And if you have found this helpful, please subscribe, share our podcast. And we look forward to seeing you again on our next episode. Have a great day.
Discover Midwives was brought to you by the American College of Nurse Midwives. To find a midwife in your community, go to midwife.org.